Yes, you are.
Yeah, I would be speaking on intraoperative imaging of after instrumentation, what to look for. So far, you have heard about various fixations options in a spine surgery, which is a varied spectrum, and also have heard about the talks about how to do it right. But however, we know that pedicle screw violations do happen, but fortunately, majority of these violations are clinically silent. But we also know for the fact that silent violations may cause instability, reduced fusion rate, and probably exaggerated adjacent segment degeneration with regards to a facetal damage. When you look at postoperative imaging, there are two components to it. One is intraoperative imaging and a postoperative radiographs. I mean, we may use CT scans or MRI some other times, but most commonly, an instrumentation imaging is basically either using image intensifier or a postoperative radiographs. When you look at image intensifier, which is one of the basic essential tools which you use during surgery, it could be a control at the end of the procedure or guidance throughout the procedure, like how we do when you are doing a MIS pedicle screw fixations. It's important that whenever you have planned a pedicle screw fixation or when you have performed a pedicle screw fixation, that it's important when you visualize to get a neutrally rotated vertebra. You heard in the earlier talks about the need to have a neutrally rotated vertebra in Neeraj talks, especially when you're putting in MIS screws. And once you have a neutrally rotated vertebra, you can divide the vertebra into 4 zones. The zone which is outside the lateral margin of the pedicle becomes zone B. The zone between the medial margin of the pedicle to the midline is zone A, and similarly on the other side. And this is very, very important, as you can see in this particular picture, when the probes have been placed and it looks like it is crossing across the midline. But when you derotate and when you make the picture centered with a appropriate AP view, with the spinous process centered between the two pedicles, you can appreciate the fact that the tips are not crossing across the midline. And this is very, very important when you are intraoperatively evaluating your instrumentation, your guide wires are following your fixation. Coming to what is the ideal screw? The ideal screw is a screw which is situated in the zone A, that is, which is situated between the medial wall of the pedicle to the midpoint. And it's also important that when you are putting a rod in, you always mobilize the head away, because majority of the time we use nowadays only a polyaxial screw head. You mobilize the head away so that the tip of the screw is independently visualized that over except from the head of the screws. That's what is very, very important. And also important that not to have a screw which is coming almost to the anterior cortex, unless in certain specific situations. 75% could be adequate, as you are all aware that the vertebra has got a convex part of the vertebral body and it varies from vertebra to vertebra. And you see on the left and on the right, this is the same length, but on the right, if you are straight ahead, the chances that you might be entering into the aorta or damaging the aorta is significantly higher. Therefore, what to look for? The tip in the zone B, that obviously means there is a lateral cutout. Tip across the imaginary midline of the vertebral body, that means there is a medial cutout. And if there is a doubt, always use the oblique view or the Scotty dog view. And you can see the end on of the pedicle. It gives a very good idea whether your screws are appropriately placed. May not be possible in vertebrae which are rotated, but in a usual scenario, especially in the lumbar spine, they are ideal to use an oblique views. This is how an ideal screw should look at the screw tip in the zone A, and the head is which are directed outwards. And it's also important that the length of the rod are not across. It is applicable much more as you come down to the lumbar spine. You've got a long length of the rod over here, which might impinge upon the facet joint below. This again becomes a problem, especially in scoliosis correction. When you think that you already used the rod, you are very hesitant to revise the whole thing, and the rod might be touching upon the facet joint below, contributing to the adjacent segment degeneration. Lateral V, in this, the screws are a bit towards the longer side, but ideally, it should be in the lumbar spine, parallel across the upper part of the vertebral body, in parallel to the upper end plate. In the thoracic, it depends upon your entry point. Therefore, when you look at the post-operative radiograph or in the C-arm, As you can see, these are examples of post-operative radiographs. You can see the head is not situated over the pedicle. And obviously in the MRI, you can appreciate the fact that there is a breach. One more example, which is the tip of the screw is crossed over across the imaginary midline. And as you can see in the CT scan, it is already crossing over. There is a breach of the medial wall of the pedicle. Therefore, when you are putting an instrumentation at the end of your fixation, visualize the image intensifier, spend few minutes of your time, analyze it, and be satisfied that your fixation is quite satisfactory. Here, one more example, you can be very obviously seen that this screw is probably has got a lateral cutout. I will also include some part of discussion about the cervical spine. It's important when you are doing the plating in the cervical spine that the instrumentation should be limited to the inferior half of the vertebral body above and the superior part of the vertebral body below. And this is applicable, much more important for a degenerative spine. Where one of the concerns following instrumentation is adjacent segment degeneration. And this part of the disc is supplied nutrition by the upper half of the vertebral body. And if your plate or extends like this, it can cause ossification, especially in other scenarios. And if your plate is coming up to here, a screws is coming up to here, it might interfere with the nutrition of the disc above. And that's the reason why we have 0P plates, which are low profile. The chance of causing adjacent segment issues are relatively lesser, chance of dysphagia being lesser. When you look at a lateral mass screws, it's nice if they look parallel to each other. You get a true AP view. Be sure the screws are directed outwards and try to visualize the lateral mass, as you can see here, and be sure the tip of the screws are not further away from the lateral mass. And most importantly, always look for the ideal position of the tip of the screw. If it is crossing across the posterior margin of the vertebral body, it is just crossing across is fine, but if it crosses further, that means the tip is not in an adequate position. Coming to the last part of my talk about postoperative radiographs. When you look at postoperative imaging, is it enough for us just to look at an implant position and think that whether it's a good fixation or a bad fixation, whether we need to revise it? Is it enough if you just say that the postoperative imaging is acceptable? And this looks reasonable. It looks acceptable. The position of the screws looks quite good. Or do you have to aim for something more when you are doing your instrumentation? We do know, if you look at this radiograph, when compared to the radiograph earlier, this one definitely looks good because it is centered exactly in the midline. The screws are perpendicular or parallel to each other. They are perpendicular to the end plate. The screws are symmetric. The screws are parallel to each other. Therefore, it looks aesthetically very good. It's basically because we do know that symmetry exists in the nature everywhere, either in the leaves, either in the butterfly, either in the flowers, or in everyday things you see around in the nature. There is a symmetricity, which we tend to appreciate. The similar applicable of symmetricity is seen in Indian temple architecture and even in Taj Mahal. And that's why we easily can appreciate them. And we tend to like structures which are much more symmetrical. Therefore, at the end of your fixation, I would say that it's important for you to aim, or a surgeon to aim, to get a visually satisfying image. And if you are satisfied visually, you can be rest assured that your patient also is visually satisfied when he looks at the image. He feels that you have done a good job of fixation. And as we are all aware in spine, the patient's satisfaction is one of the most important aspects which can go towards success in the long term. The question comes, is it necessary for us to use image intensifier throughout the step to get it, or is it possible to get it right with limited use of image intensifier? For example, to get a plate which is exactly centered over the anterior aspect, there are a few tips. One is, before you start your dissection, or when you identify the level, identify the midpoint between the two longest scoli, mark it, and then you do the dissection of the longest scoli, so that that midpoint will always remember in your mind. That is the midpoint you should aim to keep your plate in. And the second way of identifying the midpoint is to have feel the suprasternal notch and be sure that you are in line with it. That corresponds to an anatomical midpoint. Third way, majority of the systems can have temporary pins which can be placed, and to verify that you have placed the plate exactly in the center. Coming to the pedicle screws, how to get it symmetrically right. how to get it parallel to each other. One of the simplest way is, especially in the thoracolumbar areas, is to direct your screws towards the opposite transverse process. If you direct your screws towards the opposite transverse process, usually the tips of the screws are parallel to each other, and therefore they look aesthetically quite much better. Therefore, that's what we should aim for. To conclude, get it right the first time. Always verify, be sure it's not only imaging is not only to look at the level, imaging is not only to have a screw inside, but try to get it aesthetically nice. Having said that, I'm not the one who usually aims to do that, but I would definitely recommend. I've seen when you go for rounds following a scoliosis surgery, you can be sure when the x-ray is done, you can see the whole family members beaming. You can be rest assured that they are happy because they would have seen the curve correction better. They would have seen everything looks quite good. The same way, visual satisfaction is also essential following instrumentation for the patient to get a good successful results. Screw tip should be ideal in zone A. If you think there is a doubt, do not hesitate to remove the screw and check. Give also importance to the aesthetic of fixation. Thank you very much.